Well, again, thank you. Thank you so much for joining us today. You're in for a real treat with today's webinar, Leading the Way with Telemedicine. We're thrilled to bring together this esteemed panel to share their unique insights and perspectives. So without further ado, let's turn things over to today's moderator, Paula Hertel, longtime co-chair of CALA's Education Committee. Thank you. Paula?
Thanks, Jan. We are thrilled that you're all here with us on Zoom. And it seems sort of funny to me that we're talking about telemedicine and we're now all practicing on how to do training on Zoom. So our CALA Staff and Education Committee are really thrilled that you're here with us. We've heard from many of our members that this idea of telehealth was kind of cool. We're interested in it. Certainly with the pandemic, we were all thrown into how to coordinate telehealth, telemedicine. Sherry's going to talk a little bit later about what all these terms are. But we were thrown into how do we really help our residents access good quality clinical health care. And now we're sort of to the point of, is this here to stay? And if it is, what are we going to do about it? How are we going to make it a really effective use of a healthcare model in our assisted living and senior living communities? So today you really are in for a treat. We decided we really needed to bring the best of the best and the brightest to have a really open discussion with all of us about what is telehealth, what is telemedicine, and we sort of use it interchangeably here in this webinar. And what are some of the really innovative things that companies are doing? And then what are some of the challenges? And one of the things I love about senior living and assisted living is that we are really open to talk about what is working and what isn't, and what are we challenged with, and how can we all rise up together to better help our own communities, our residents, our families, and our team members. So that's what we hope to provide for you today. Jan, if you move on to the maybe the objectives, and what we're hoping that you'll come away with today is a really in-depth look at how providers are looking at practical information and how they're really integrating healthcare into their operational protocols and their systems, and what policies are changing and what policies are not changing because of the integration of telemedicine and telehealth. And then learning how physicians are utilizing telemedicine for specialty services. And Dr. Zhang is going to talk to you about some research that he's involved in using telepsychiatry, and really excited to hear more about that. And then lastly, that you gain knowledge about the policy, regulatory, and legal considerations that operators are faced with as they enter into more integrated and just larger expanded telehealth protocols. So with that, you can go to the next slide, Jan. We've set up this webinar in a way that we're going to allow our panelists to give you some foundational information from their perspective. And then the second half of the webinar is really meant to be interactive for our panelists to discuss some of the questions that you have, some of the questions that come up through this webinar. So please, through the question and answer icon at the bottom of your screen, if you type in those questions that you have for any of the panelists, I'm going to do my best as the moderator to grab those themes and make sure in the second half of this webinar that we're having the discussions with Sherry, Dr. Zhang, and Alan. So with that, I'm going to introduce you to our panelists and then we'll get started. First, I want to introduce you to Dr. Glenn Zhang, who's a clinical professor at UC Davis Department of Psychiatry and Behavioral Sciences, and is also affiliated with the Alzheimer's Disease Center at UC Davis, as well as being the Chief Medical Officer for Safely You. He's overseen numerous projects developing and exploring applications of telemedicine to support assisted living and skilled nursing providers. Dr. Zhang earned his medical degree from UC Davis and completed his residency training in psychiatry and internal medicine at Duke University Medical Center. So thank you for joining us today. Also, I'm thrilled to introduce to you Sherry Easton Garrett, and she's an RN and is a Senior Vice President of Clinical Services for Belmont Senior Village. Sherry has 25 years of experience working in integrated clinical programs in operations in assisted living and senior living, has been part of innovative medical technology, research, operations, and healthcare leadership, focusing on all the senior living continuum. She's focused on advancing research and clinical capabilities within assisted living and has participated in all sorts of really exciting things that she's going to share with us today. And finally on our panel is Alan Jurgensen, who is a partner at Hanson Bridget. And Alan has extensive experience in senior housing and long-term care. His work in this area covers a broad range of legal and regulatory work, including his expertise in HIPAA, regulations, confidentiality, privacy laws, telehealth, and medical treatment questions, resident rights, and government relations. He's a graduate of Harvard Law School and holds a doctorate of philosophy from the University of Oxford. So as you can tell just from the resumes of our panelists that we have an incredible amount of experience here today, and we look forward to sharing this information with you and starting a dialogue. So with that, I'm going to turn it over to Sherry, who's going to start off with the presentation. Thank you, Sherry.
Yes, ma'am. All right. Thank you, everyone, for joining us today. And I started thinking about how, you can go to the next slide, please. How everything, you know, that I feel like I see nowadays is tele something. Of course, my kids are always asking me for the newest telephone, their iPhone. And they just really don't appreciate when I tell them my first phone was 2 tin cans and a string. And then fast forward multiple numbers of years, more than I care to think about, add a pinch of a pandemic, and now we have telecommute, telediagnosis, telepresence, telesurgery, televisits, telemonitoring, telemedicine, all different kinds of things that basically what are we providing and what are we providing remotely? And that's really what I kind of want to get to and talk about. How do we get from here to there? So next slide. So I believe in the K.I.S.S method. So hopefully everybody knows what the K.I.S.S method is, but just to restate it, it is keep it simple, Sherry. So I try to make things as simple as possible for, you know, to understand, but then make sure that there's all the research behind it. So starting with the K.I.S.S method, we're going to look at problem, plan, and implementation. And then I'm going to review some of the lessons that we learned when we implemented a urgent care telemedicine program. So next slide, please. So identifying the problem. This seems like a really simple step, but that's really where you start. You want to be able to simply articulate what is the problem that you've identified? What are you trying to solve? Why are you trying to solve it? And then see if there's technology that can assist. So many times I see people find some really cool technology and then go looking for the problem. When it's really, once you identify what is it that's your needs that driving it, then how do we leverage the right type of technology or telemedicine or telehealth as we're using that interchangeably. And that will help you in what type, for example, with our telemedicine, it would help direct in what type of technology we're using, because we're using the teleauscultation, we have EKG, we have otoscopes. So it's a matter of identifying what your need is and then how you solve it using the right technology. Identifying the market forces, which actually can range from drivers to barriers. So it's looking at that along identifying all of the market forces. So for example, the pandemic created this market force of tele-everything, telecommute, televisits, virtual visits. So those are like what the drivers, but also it's important to identify the barriers. infrastructure, resources, liability, sustainability, productivity, all of those items too. It's important to identify the barriers. Organizational readiness. I kind of chuckle when I hear organizational readiness because in trying to keep it simple in my mind, I see if any of you guys have kids and you've heard of SpongeBob, and SpongeBob is so excited when he goes to work and it's I'm ready, I'm ready, I'm ready. I love that enthusiasm and bringing that energy to items. But it's when we look at organizational readiness, it's about looking at, especially in the middle of this pandemic, what can we bring on? And that's why when we looked at telemedicine, identifying our problem, which I'll get to towards the end, it was really important to do small tests of change and identify the readiness and the ability kind of along the way as well. Defining the program model. This is where you want to know the who, the what, the where, the when, the how, and especially the whys. That's one thing throughout all of any program that you do. You need to let your inner 2-year-old voice come through and always ask, but why? But tell me why, but why is that? And drill down multiple times. And it really helps get to kind of the root of what you're trying to do. So when you're defining that program model, keep asking the why. What service is needed and why is it needed? And can you measure it? Why or why not? What mode of delivery is the best? Why is it that you think it's the best? What's the benefit of it? Who will provide the service? Why that individual or that job classification? What constraints can you identify and why? How do you know that they're constraints? Are they actual constraints or perceived constraints, and why? When will the program be provided? And that's going to have a lot to do with how you identify what is your need and why. So if you have a specific time limit, just identify we're only going to do this from this, from 8 to 2. Okay, well, why is that? Does that address the time that you have the greatest needs? And what legal or regulatory considerations do you need to evaluate and why? Other is to outline your business case. So outlining that, I look more at identifying your resources, right? And how do you identify those? How do you measure those? Identifying that as, I look in 3 big buckets: people, time, and money. So when, especially any type of telemedicine or telehealth program implementations, because I've worked on several throughout my history, and anything, I always break down to a resource analysis, people, time, and money. Reimbursement options. That's another thing to consider, especially, in this new era that we're moving into, because there's a lot of talk about telemedicine, telehealth. Will the waivers continue? How can it be adapted into what we do? Is there sustainability in it? So a lot of things to look at around there, and why. Is it sustainable? Why or why not? Next slide, please. So the plan. You guys have done this throughout many projects and programs you've implemented. The thing is to identify the key steps and identify why are those key steps. So you want to focus on the most important and why they're the most important. And hopefully that's going to also relate you back to your problem. Define key tasks and roles and ways to measure that. So that's really important in some of the lessons that we learned, because being in the middle of a pandemic, we were already at maximum, productivity. And now you bring all the things that we added into the pandemic, the testing and the assessments and everything. you start really stretching your staff really thin. Determine your resources. Again, people, time, and money. But a key is to, especially when implementing telemedicine programs that change a clinical workflow. You're changing really kind of the way care has been provided, and you get it's always been that way, or you get what I call the DWANAs. I don't want to do it, and then you're like, why do you not want to do it? I just don't want to do it. So really identifying, aligning people, time, and money, but also having your champion. That is one of the most critical things I can say about any of the telemedicine research and programs that I've implemented. Adjusting policies, procedures, processes for the operations aspect is key. Not only for clearly outlining your definitions, but for having those also as well for legal reviews as well. Develop training focused on who, what, when, where, how, and the whys. It's very important. Establish your timelines, but build room in for the unknowns. Because unless you just have the luck of the Irish, you're going to have a lot of unknowns. Develop monitoring programs. So you need to be able to measure, track, and evaluate. And again, that's going to flow back into your problem. That's why you want to be able to clearly articulate what is the problem that you're trying to solve for. And identify how your data is collected. And the expectation of stakeholders, which residents, families, staff, the telephysicians you're working with, the primary care physicians. So the stakeholders all along the way, identify those, start looking at what are the expectations of that. You want to go to implementation. Next slide. Thank you. So pilots, okay, so they're not just for airplanes, they're for everything. I am a true believer in pilots and rapid cycle learning, small test of change, plan, do, study, act, implement something, evaluate, improve, implement, keep going back in the cycle. So pilots are excellent. Implementing your plan. So here I think pencil versus Sharpie. It's okay to make mistakes, to go back to erase, to go back to evaluate and change your plan. It's okay to do that. You don't want things to be on a linear. You want them to flow through a loop and continually evaluate. You want to be able to measure your outcomes and how does this compare with the initial assumptions that you have when you identified your problem. Train. I sometimes, when I talk about the lessons learned, I just thought, oh my goodness, I thought we just trained on that. But you have to go back. Once you thought that you've trained enough, you probably need to go back and train some more. That's been very interesting in training and bringing in new concepts, but also, you're bringing it in the middle of a pandemic. So that is very, very important. What changes are needed to ensure that you meet the program objectives? So you want to make sure you have clear performance indicators, and then keep going back to the problem. Did we address it? Again, that rapid cycle learning, that adapting, building in the things that you've learned. Next slide. Okay, so lessons learned. So sometimes you just have to be the first penguin. You just gotta jump. So I can tell you the lessons that we learned in implementing a telemedicine program. And again, it's like all of you guys on here, right? You're in the middle of a pandemic. You're still trying to figure out, okay, what's going on? Everything is changing so quickly. And then we notice now we have You know, in the middle of it, we have ambulance that don't want to come to the community and don't want to take our residents to the emergency room. Not that you want people at the hospital, because they were, you know, dealing with the pandemic and the rationing of care. And so we identified a need quickly. We need to give our clinical team, we have nurses 24/7, so we need to give them additional support so that they're in the middle of triaging everything. So we need to give them additional support. So what can we do? We can get physicians 24/7 so that they can be contacted at any time, which is what we had a team that went out and researched that. It's part of our you know, pandemic response team. Went out and researched what can we do, what can we scale up, what can we do quickly, because time was of the essence too. So we identified, all right, this is our need. We need access to board certified ER physicians 24/7. We need to have them ability to evaluate and determine next steps. So we developed the program around that. So along the way, we learned a lot of really important lessons. But one thing that I would always say when you go back and evaluate something, you got to look for those Easter eggs, you know, those little things that you find, those aha, oh, that's really cool. And what's the surprise inside? So one thing with our program was the consents. They had to have pre-consents before we use the service. So if you're gonna call somebody, have a fall at 2 a.m., you know, we need to know, did the person already pre-consent? And that relationship was with the resident and the physician. And then if so, then we would utilize the telemedicine service for that. We initially started out to where we could do the consents at the time because you could also get the family. Most of the time the families would join the televisit with the ER physician and be part of that team, which created great transparency, engagement. But on the other end too, that was taking a lot of nursing time to do that initial consent process. Then we took that out. That is an area that we still see opportunities for improvement to evaluate our consent process. We have right now, we have about 20–25% of residents that consent. So what we see is that it's more need type driven. Learning to anticipate interruptions in workflow. I mean, really, we found that we need a lot of training with our nursing staff. And we've changed how we train. We had small focus group with nurses and went back to a scenario-based simulation training on different scenarios before somebody was competent to telepresent the resident. But one of the things, the Easter egg thing, I'll say that we found during the training is because if you think about every time you train something, you're increasing that critical decision making. And so as we train on, you know, telepresenting and how you evaluate and how you present a situation, and you know, ours was focused on urgent care, emergent, you know, looking at is this an emergency that needs to be transported or not? As we increased our training and talking about, you know, using SBAR and how we triage kind of communication, focus on the most, you know, effectiveness communication. Guess what? Our documentation improved as well. So that was some of the aha for us, and looking at things, kind of broadening that scope. And then identifying clinical indicators. That was a big thing we created triage levels based on the stoplight system, and then put situations into that and created pathways, which was extremely helpful then for our staff. You know, in the end, basically we found that we had already a low transport, less than 20% transport to the hospital. We're evaluating now, we have about a 9% opportunity to even improve that. So it is an ongoing process, and I'd love to hear any questions or thoughts that you guys have on it. But for now, I'd like to turn it over to Dr. John.
Thank you, Sherry. Thank you so much for that great presentation and synopsis of how your program is adopting urgent care telemedicine. So I'm going to start really more from a sort of a historical perspective. And I think just like all of you are by now have really figured out how to do a lot of things virtually. I would say that our physician trainees, our medical students, our residents are actually just like everyone else are actually starting to learn how to practice medicine because of the pandemic. Telemedicine, the practice of telemedicine or telehealth actually has been going on for a couple of decades, probably even longer than that. Traditionally and historically more for rural settings, for areas that are very hard to get to. And as you know, health disparities is more than just distance, right? So we're learning, I would say in the last in the last five to 10 years or so, that the health disparities within our own metropolitan areas is tremendous, right? As also brought out by the pandemic. So I'm going to sort of go over all that, and hopefully I will also cover sort of some of the really good indications for telemedicine. So you may want to look at your own programs and really consider what your needs are. And then think about how and what type of telemedicine makes sense for you. And as Sherry indicated, because I've had the experience and opportunity to work with a variety of programs, I think she's right on. Not only do you need to really have a sustainable model, but just the implementation, you really need a champion at the ground level who really believes in it, who's willing to sort of like that penguin, take a little bit and just sort of jump right in, because you know, everybody else may be waiting, but until you start doing it, you're going to start gaining all the experiences and getting and understanding what the barriers are, and then problem solve through all that. So next slide, Jan. So just quick background. So telepsychiatry or telemental health actually has been going on, like I said, for 2 to 3 decades. So even 5 years before the pandemic, there was this really nice review. And even at that point, as you can imagine, these clinical studies can take anywhere from 2 to 5 years to complete, and then another couple of years to be published. So even back in 2015, there's a solid over 130 studies that have reported on sort of the implementation and the practice of telepsychiatry and telehealth. Guess what? Healthcare professionals are actually not that they don't really embrace telehealth as you think they do. A lot of providers actually have concerns because they're sort of trained in the traditional model. They like that in-person contact. Their concerns are, well, you know, not having someone come into my office can potentially impair that therapeutic relationship, especially for psychiatrists. On the flip side, though, the patients themselves actually have a better or higher satisfaction than the healthcare providers. And there's a number of reasons for that. So let's say if I'm used to running a practice, my schedule is actually quite nice as a provider. And then it's better for me to have this particular schedule rather than sort of as a provider, then you also have to work with someone else's schedule when it comes to telehealth. And then there's a number of no-shows, there are a number of technology connection issues. There's all these little logistical barriers you have to run through in order to have sort of that very reliable treatment modality, getting good history, for example. Clinical outcomes, as it turns out that depression treatment, and as well as other types of treatment, that there's usually perhaps telepsychiatry may be better in a lot of circumstances, but at least at a minimum, that the outcomes are such that generally the studies are fairly equivalent, whether it's delivering medication or delivering psychotherapy. Interesting. The barriers to reduce in terms of getting people into appointments. And we're seeing that actually throughout the pandemic. This particular study showed that to get someone into that first appointment, people were 18 times more likely. So 18 times, that is what, 1800 fold, right? Or percent, in terms of getting people into that first appointment. So the reduction in terms of barrier to mental health services is tremendous. And I will say that this is shown throughout the pandemic in terms of no-show rates to mental health appointments have reduced by at least 80%. No-show rates is one of the biggest concerns in mental health systems. Someone will be in a crisis. You try to make an appointment. Actually, somewhere around maybe only 20%, maybe even less of those appointments actually happen. Next slide. And I'm going to watch my time for a little bit, just to make sure Alan gets plenty of time for his part. So I want to share with you sort of the research study that I am involved in, sponsored by the Agency for Healthcare Research and Quality. This is an arm of the NIH. And we call this the CATALYST study because, again, we having done this for a while, we recognize that just there wasn't sort of enough. There were a lot of barriers in terms of people wanting to do this. Let's go to the next slide. So this is a way we did, we called something called asynchronous telepsychiatry, because even synchronous telepsychiatry, there's a lot of barriers. So synchronous meaning the telemedicine that that particular part requires a clinician on the other end who has an open schedule, who is ready to receive calls for telemedicine, as well as some of you may have experienced hosting these calls on your end or coordinating these calls. You have to get a coordinator. You have to make sure the patient's ready. You need to make sure that if it's a Zoom meeting, they have the Zoom link or the Zoom ID, and as well as the password. If it's some other type of platform, you need to make sure you have the platform. On the clinician side, this is an example of that, is you need to have an EMR system that's coordinated. And if you don't have an EMR, you need to make sure you get a fax record of the medical history, the medication list at a minimum. The pharmacist nowadays, you need to know what is the default pharmacy, because most pharmacies are done, most prescriptions can be done electronically. And then you need to have that video platform. So what we ended up doing with asynchronous telepsychiatry is, so asynchronous, one common way of asynchronous communication right now that you all do is texting. So very similar to texting, if you can imagine that text script comes in the form of a video. You're also getting videos and photos, right? So asynchronous telepsychiatry involves an interviewer going and perhaps visiting or via telemedicine, conduct an interview that is recorded. And then that interview is then observed by a psychiatrist or another diagnostician to come up with a diagnosis and then a treatment plan. So again, this is obviously, pretty novel and unique, and this is why you have to be able to show some novelty in order to get one of these awards from the NIH, right? So next slide. So this is the preliminary data to our current study that is actually ongoing. So we were fortunate to do this in 2 nursing homes, and we did a asynchronous and then versus a synchronous, because the synchronous we consider it as a default or a standard of care. And really about this, because the study was pretty small, there's some differences in the 2 groups. Next slide. The overall outcome, this slide basically indicates that the primary outcome in terms of the clinical global improvement, it was pretty much equivalent when you compared the asynchronous versus the synchronous groups. And next slide. So this is the status of our current study. We're actively involved in 8 skilled nursing facilities in the greater Sacramento area. Actually, one of them is in Fairfield. As we sort of did, as you know, that the nursing homes got hit very hard during the pandemic. So we were actually about, I want to say about 3/4 done, and then the pandemic hit. So we're still in the process of wrapping up this study, but it is ongoing. And you can see here that because we have a larger sample size, that the baseline characteristics are pretty equivalent for the 2 groups. Next slide. So that is sort of the that was kind of just a preview of the study that we're about to finish. Actually, we're going to probably wrap up in the spring of next year. So when it comes to clinical conditions, so if you take behavioral health as a model of a chronic condition, other chronic conditions like hypertension, diabetes, chronic pain, dementia, hypercholesterolemia. So if you think about it, the initial diagnosis of those conditions, certainly in an ideal setting, it would be great if those diagnoses and workups were done via in-person care. But the follow-up of those conditions, actually, for hypertension, you really need is the blood pressure. For diabetes, you need a blood sugar. Hypercholesterolemia, you need the lipid status. For pain, you would be able to evaluate how the pain is after you've started a treatment. So chronic medical conditions are just sort of intuitively, they work out for using the telehealth platform. And I'll speak a little bit more about the hybrid model in a bit. So what are the advantages of telehealth for chronic medical conditions? Well, first of all, ideally, you would be able to see the same physician that you saw via in-person care. Second of all, you really reduce the need for transportation, if not just in terms of in-person contact and avoiding infections. Now, let's move to urgent medical conditions. Urgent medical conditions are a little bit tricky, right? So do you go and visit an emergency room, or is this something that you would take care of in the doctor's office? Well, if you can take care of this in the doctor's office and not go to the emergency room, can telehealth resolve some of this? And I think that is where currently there are a lot of urgent telemedicine practices, because in actuality, you can probably take care of about somewhere around 75 or maybe even 80% of urgent medical conditions. And finally, I think we all have some agreements, right? So there's certain more acute, severe medical emergencies that you just cannot take care of using telemedicine. So for example, if there's a physical injury, if someone has a fracture, someone has a big laceration that requires sutures, you go to the emergency room. You wouldn't want to sort of really even think about waiting for a telemedicine visit necessarily, although there's occasionally a telemedicine specialist can sometimes better triage these conditions. If someone is having a heart attack, a stroke, blood clots, bleeding or hemorrhage, and then during the pandemic, respiratory failure. Those are medical emergencies that you definitely want to go to the emergency room directly. Now, I think the trick part is how do you distinguish those two? And this is where you need someone to help you triage. You need a medical expert to really decide. The important part, even with urgent medical conditions, is there is multiple visits, right? A lot of these conditions, you may want to consider a telemedicine visit, and then we often pretty much almost always stress a follow-up plan. Sometimes a follow-up plan could be, well, if the condition doesn't get better, or if the pain increases, you may need to go to emergency room. So I would say that whether conditions, whether you would want to consider using telemedicine, it's not always black and white. It's sometimes there's a lot of gray in terms of triaging and taking the next step. Next slide. So my final slide is really, I think we're going to get to a point where even for most of the physicians that you're working with in your facilities, they are going to start to become more ready and willing and capable of providing telehealth visits, that they're going to start offering that to your patients. And because, again, as patients who are consumers, they actually enjoy that modality, it may actually improve that treatment experience, because it increases the frequency of those visits. Keep in mind those people who are willing to start a first visit to see a mental health specialist, that was increased by 18-fold. Right, so there's going to be more people willing to seek healthcare via the telemedicine platform. Period. And I think that if you are able to support that in some way, your residents are going to find that beneficial to their overall health. And then finally, as a facility, your residential care coordinators then are a little bit more in tune to the well-being and healthcare of your residents, and thereby, all that leads to better care coordination, better outcomes. And then as physicians, we actually don't know, most physicians don't know much about long-term care, whether it's skilled nursing or assisted living. So by that telemedicine platform, you're inviting healthcare professionals to really get to know your program. I will end there, and our next speaker is Alan Jurgensen. And Alan, please.
Thanks so much, Glenn. Happy to be with all of you today. When we were planning this webinar, we knew we were going to be talking about operational matters. That was Sherry, of course, clinical matters, Glenn, and then legal matters. And the question was, well, in what order should we do it? And I think we wisely decided to do the operational and the clinical first, so that we could show you what the possibilities are, what the challenges are, how it can help, what the limits are, et cetera, and then leave the legal stuff to the end. And sometimes I think people wait for an attorney to come on to say, oh, you can't do this, here's the danger, oh, you're going to be held liable, et cetera. And that's not, of course, what we're here for. And that's not, of course, what I'm here for today. I'm really here to follow on Sherry and Glenn and to tell you what the possibilities are, and then also to tell you what the boundaries are and what we do know and what we don't know. And what we're going to see is, as in operational and clinical matters, the legal side is expanding and changing, and it's been accentuated by COVID-19. There may be a little bit of a retreat away from telemedicine when COVID-19 is over, but I don't think very much. I think it's here to stay, and the legal system is recognizing it. So next slide, Jan, please. I have 7 bullets here, and these are the topics I'm going to be covering. We're going to talk about what kind of responsibilities do assisted living facilities in California have to provide telemedicine, or at least to facilitate it. Then with responsibility, of course, comes potential liability, and we lawyers can't get away from that. And I'll talk to you a little bit about what that means. Then a very particular topic, and that is what happens when the physician is out of state. Now, not a problem if the doctor is just across town. The doctor will be licensed in California, not an issue. But when RCFE, usually large RCFE providers, start contracting with out of state telemedicine companies to have care provided by out-of-state physicians, there are issues of physician licensure, out-of-state physicians practicing in California. We'll talk a little bit about that. Sherry has already brought up some of the practical questions having to do with consent to a telehealth or telemedicine interaction, and I'll give the legal side of that. And then we can't escape HIPAA and privacy. It's on everyone's minds these days, and so we'll talk a bit about that and how it hits us in the assisted living space, as opposed to, say, the doctors who will be actually providing the distant interaction. Security is just the other side of the coin. The HIPAA security rules having to do with how you maintain the integrity of electronic information, and particularly health information that is being transferred or transported between the distant site physician and the originating site patient at the RCFE. And finally, I want to say a little something about reimbursement for telehealth services. Medicare has already done some innovative things. They've warned us that they will be looking at it again once the pandemic ends, and maybe pulling back on it a bit, but they're beginning to open up things as a practical way for getting reimbursement for those services. We'll see that mainly it's reimbursement for the distant site physician, and we'll talk a little bit about that, but also more importantly for this audience, what it means for the assisted living facility where the patient is located. All right, next slide, please. And let's talk about RCFE responsibility. The Department of Social Services has said very little about telehealth, but it has said something. And it came out with a PIN in September of last year called Assisting Residents with Telehealth Visits. And this is interesting. Just the title really points us in the right direction. It doesn't say providing telehealth visits to residents. Or providing distant site physicians. It says assisting with telehealth visits. So the points below it make it clear exactly the approach it's taking. And that is, telehealth is part of the overall obligation to provide assistance to residents in meeting their medical needs. Okay, yeah, we can't deny that we got to do that. And I suppose telehealth is a new modality. But it's our responsibility is not in providing a certain level of telehealth interaction, but rather setting up or logging onto a telehealth visit and assisting a resident with essentially the computer features there. So it's really, at least as far as it's going in this PIN, really assisting with the electronic interaction, but not necessarily doing some of the other things that Sherry and Glenn have noted, and what I will note as we move along. Okay, it does say recognize that there may be a need to have staff present, but to assist with the technology. Again, they're not saying that you have to have healthcare professionals, RNs, quasi-professionals there in the assisted living facility, actually assisting with the interaction with the health side of the interaction, but rather just assisting with the technology. And then finally, they note, of course, that residents, when they see their doctors in person, and the same virtually, that they may want or need to have a representative present. We'll talk about what that means when we talk about privacy later on. Next slide, please. So the way I've approached this to try to figure out what is the RCFE's responsibility is to ask, well, what's the possible range of an RCFE's involvement? And those two sub-bullets there give the polar ends of it. So the least involvement, imagine a resident in their own unit living independently, and they've got a computer. They're pretty well hooked up to the system. They go on to their physician's website and do an interaction for just a routine care, something that you or I might do at home. And in that case, I would say that the RCFE is least involved. Now, I suppose, according to the PIN that we just talked about, if the resident, if we sense, if we know, if the resident tells us, I'm having trouble with the technology here, well, that's like assisting a resident to make an in-person visit to the doctor across town, or at least doing something to see to it that they're able to complete that. So that would be the least amount of involvement. Then we go to the other end. Greatest involvement, oh my goodness, look at this, arranging for the interaction. So now you're arranging for it in a community space. So that's, we'll say, downstairs in some room, using your own equipment, including, as matters progress, possibly sensors and things like that, with the assistance of a health professional, maybe an RN, maybe a medical assistant, not a physician, to assist with the interaction, and then having the remote physician being someone that the RCFE has retained. And we've had clients, usually national clients, that contract with outside telemedicine companies, and the outside telemedicine companies provide the physician under contract and so on and so forth. So there's real involvement there, and we'll talk about that when we get to liability. And then treating, let's say, the whole range of routine, urgent behavioral health conditions. Glenn explained all of that and what the benefits and the limitations are there. So that's the possible greatest involvement. And I doubt if many are way at that end. Many RCFEs are way at that end, but who knows, in the future it may be there. And my final point there when I'm talking about responsibility is to emphasize that any RCFE needs to know what its role is. What is it going to provide? Is it at one end? Is it the other end? Most likely it's somewhere in between, and it's going to depend on the resident and the circumstances. So you have to know that yourself in order to avoid situations where, say, not enough is done, and then later it's said, well, the assisted living facility should have done this, that, or the other thing, should have had better equipment up to standard, should have had the right quasi-health professionals there, should have done this, should have done that. So you want to be clear to yourself about that. And I can see putting that in some sort of internal policy or procedure or protocol. Question came up when we were discussing this. Does it need to be in the RCFE plan of operation? The RCFE plan of operation regulations don't say anything about that. So what I would recommend is, if you really know what you want to do, and especially if you're at the higher end of involvement, then you ought to put something in your plan of operation. But at least for now, DSS is not going to require it. Okay, next slide, please. Liability, oh boy. Now, there's just a general standard, the due care standard, that says that you have to act according to the proper level of care in doing what you do with residents. So that's maintaining at least some awareness of the resident's health, and I would say of telehealth interactions, and then intervening as necessary and appropriate. What if you find out that a resident who routinely visited their physician for a condition that really needed to be looked at and cared for was not doing that? Not surprising in the pandemic. and that maybe, I don't know, they were trying to connect via telehealth, but were unable to, and that had come to your attention. So you need to be on the lookout for that. On-site assistance, again, that's something that you may or may not do depending on your degree of involvement, but make it clear and make it clear to them and to the outside physician what your role is. And then this is in a way the trickiest. It's where you have contracted with an outside, say, telemedicine, telehealth company. There you've got to at least satisfy yourselves that the doctors they are providing and they are recommending, and remember, all they can do is recommend. It's up to the resident and their family to decide whether to use these folks. Make sure that they do the proper screening so that the distance site doctor is competent. Possible role of the medical director: the more you do, the more involvement your medical director is going to have in overseeing the system, monitoring it, that kind of thing. And then I would say check your liability insurance for coverage through your broker, et cetera. I don't have any special insight into that. I haven't had any experience with it, but I'd say it's something that you need to do. Okay, next slide. Distance site physician licensure, I'm going to go over this pretty quickly. It's tough. As I said, if the distance site doctor is in California, across town, whatever, you're all in California, not a problem. It's when you have doctors practicing across state lines. This is not entirely new with the COVID-19 pandemic, but it's been around for a while. And various states, including California, have rules about what out-of-state doctors, meaning doctors who are licensed out of state, but not in California, what they can and cannot do. And there's some exceptions there. This has nothing to do really with COVID-19. There's something called the Interstate Medical Licensure Compact. About 30 states are part of that, and they allow expedited practice across state lines. We're not part of that. States with bordering state exceptions, you can imagine that in a place like New England, but we don't have it. And then states allow out-of-state practice where the doctor doesn't routinely practice there. The initial contact is in the patient's state, and the physician maintains professional liability insurance. The initial contact part is probably what you're not going to have if you have a RCFE resident interacting with an out-of-state physician. Next slide, please. California is pretty liberal in this generally. It allows consultation, but observe, this has to be with a California physician. So if you're doing this and you want to be absolutely safe, unfortunately, you'd have to have a California physician at the originating site in the RCFE where the resident or patient is. Well, that in a way defeats the whole purpose. So that's not going to help. And then, very importantly, there have been waivers for out-of-state physicians during COVID-19 care. This is something that's going to have to be addressed more broadly by the Medical Board of California once COVID-19 is behind us, and we need to be figuring out how to sustain telehealth on a long-term basis. I'll talk about Medicare reimbursement at the end, but right now the point is Medicare has said, again, during the pandemic, they will not deny payment because the physician was out of state. Now observe, this is payment to the physician. We'll talk about that more at the end. Next slide. Consent. Okay, Sherry talked about this, and I want to say just very briefly what the obligation to obtain consent for anything is on the treating physician. So that's everything. What's going on? What's the patient's condition? What are the proposed therapies, treatments? What are the benefits, risks, side effects, all of that. And it's of course very important if you're planning a major surgery, which I suppose at least the consent discussion could be via telehealth. But if you're talking about routine care, not so important because consent or patients, residents are deemed to understand, their families, what's involved when you're talking about routine care. If it's an emergency, such as Glenn was talking about, consent is implied, and so it's less important there. But I've added the telehealth consent elements. There really should be at least some mention somewhere, preferably in an oral explanation about the benefits of remote video, audio interactions, and then the risks, the dangers of miscommunication, et cetera. Someone ought to do that. We look, consent lawyers say, oh, it's always in the course of a oral discussion, and then it should be verified by a consent form. So I would recommend that. Next slide. Privacy, okay, HIPAA stuff. Privacy, when we talk about it, deals with the confidentiality of the interaction or of the information shared, as opposed to security, which we'll talk about next, which is how you maintain the integrity of the electronic communications. So now, a big point, everyone's always talking about HIPAA. HIPAA has come to stand for just about anything having to do with privacy, even the privacy of non-medical information. So we need to get our analysis clear here. HIPAA and its California equivalent apply to the distant physician, but not to the RCFE. For the most part, except in very narrow circumstances, RCFEs are not subject themselves to HIPAA. And so the burden is really on the physician under HIPAA, but we have licensing obligations in Title 22 to maintain proper resident privacy, et cetera. It's just that there's no detail about it. So we need to be concerned as well. Particular questions that have been asked about confidentiality is, can the physician share resident health information with resident representatives? Absolutely, yes. No need for any written consent if the residents are there and clearly are acting on the residents' behalf, no problem. Can they share it with the RCFE personnel? Yes, again, HIPAA is a technical analysis, but what it says is RCFEs can receive health information from HIPAA-covered entities, in this case, the distant physician, without having to get any special written authorization. They're part of the overall healthcare provider team. Next slide. Yeah, confidentiality of the information created. This is still under privacy. It's the physician's medical record that really has to contain the information, but with the RCFE involved, especially if it's involved in having supportive quasi health personnel there, then there should be proper documentation of the interaction in the resident record, and that needs to be kept private as well. Next slide. Security, as I said, deals with the integrity of really the electronic transmission process. And the HIPAA security rules don't apply to us, they apply to the physician. And what they essentially say is that the physician, but us as well, have to take steps to prevent the improper access, exfiltration, destruction, et cetera, of electronic health information, including information about this interaction. Next slide. Now, people say, well, and some of these telehealth companies say, well, we're HIPAA compliant, and therefore don't worry about it. Well, there's no such thing as formal HIPAA compliance. The HIPAA authorities do not give special dispensation there. And so what you have to rely on is just the general ability of your system, if you're doing it, or the outside doctor's system to maintain the security. I note that, in the last bullet point there that in light of the COVID-19 pandemic, the Office for Civil Rights of the CMS came out with a statement saying, if you use commonly available non-public facing platforms for interaction, that's okay. And an example is Zoom for healthcare, as opposed to Zoom generally, which is considered to be public facing. So make sure that that is used. Okay, next slide, we're almost there. Yeah, a reimbursement. Okay, Medicare has expanded during the pandemic, and we're really talking about Medicare reimbursement to the physician, which is of less interest to us. I've given 4 bullet points there, which were previously limitations that have been removed. And I'm not going to go over them in the interest of time, but there you have them. And then the final slide. People ask, well, is Medicare going to reimburse us? No, we're not Medicare providers. And so we're not going to get any direct reimbursement from Medicare. In theory, we might get reimbursement from the professional component. Remember, I said that doctors are getting paid by Medicare in ways for telehealth in ways they never were. And one might argue that, well, that contains a certain element of physician overhead, which would be possibly a payment to us. It would be pretty small, quite honestly, for whatever we do to assist in the interaction. I don't think it's going to happen. It's an interesting idea. I'm going to skip over illegal referral fees. That's a rather technical thing that probably at this point only a lawyer could imagine. And then private payors, that's subject to state HMO and insurance laws. And generally what they say is that you have to provide reimbursement again to the physician for a telehealth visit in the same way you would for a face-to-face visit. Okay, that's my thing. And so I think it's now time to turn it back over to Paula for questions and so forth.
Thanks, Alan. I think we're all going to come back on screen. And this is the opportunity for us to really get into dialogue around. I feel like I have to take a deep breath. We went through a lot of information in a short amount of time. So again, for the audience, if you have specific questions, please continue to type them in the icon under question and answers, and I'll do my best to grab them. The one thing that has come up through this webinar is this whole idea. I mean, we've talked about telemedicine, telehealth in terms of primary care, remote and audio visits, urgent care, emergency care, psychiatry, mental health, specialty care. We didn't get into a lot of details about the biometrics and some of the technology that's coming to play and that has sort of pushed forward so quickly with the pandemic. But all of that is sort of front and center. And Dr. Zhang, it's sort of interesting that you reminded us that telemedicine has been around for a long time. And I think mostly around, you know, for access in rural areas and places in follow-ups that weren't necessarily typical to senior living and assisted living communities. But now here we are, and it begs the question for operators that have talked about we're not a medical model, and we talked a lot today around how we as senior living operators work with residents, families, and healthcare medical providers in setting up this. But what do you say to people that say, hey, wait a minute, we're not a medical provider. Now we're really getting entrenched in helping clinicians with interventions, with treatment, with clinical observations. Like I'm just interested to hear from all of you how you respond to that concern. Sherry, do you want to start?
Sure. You know, I've heard that in my career in the field of, you know, we're a medical model, we're a social model. And probably being the nurse in the group, I'm maybe not the right person to ask, but I see more of what we do as a person model, you know, in that all of us are trying to meet the needs of the individual where they're at, right? Their psychosocial, spiritual, we're all connecting. We're all a village that's built around to meet the needs of this individual. And so I don't really think, where is that line? Where is that social? Where is that medical? More around what is it that we create in that interdisciplinary team? And we all have them. We have therapy programs in our communities. We have pharmacy that we worked with. We have we had med reconciliations that we know that the pharmacists do when we send in a new resident and they get the list of the meds. So to me, it's all a blended model that, I'll just say it's a person model. That's whatever we're doing as an industry, whether it's social or whether it's medical or whether it's blended, it's all to the resident. So, but I'm going to KISS. I'm going to keep it simple, Sherry. So that's my simple answer.
Alan or Dr. Zhang, any other comments you want to make?
Yeah, I'll take that as well. I would say that I agree with Sherry. I don't think I pretty much believe you shouldn't assisted living program should not be a medical model, right? It should be holistic. It should be based on the needs of your residents. What I am seeing, right, is that the medical needs of our aging population is increasing. So it's really not whether you are you're trying to be a medical model. You're just kind of keeping up with the needs of your residents, right? You're trying to keep up with the technology needs. You're trying to keep up with how they receive medical care. And I think there's the one where if you were to do a survey, you probably have residents, especially in your independent living, who are getting a lot of telemedicine because that's what their healthcare professionals are giving them. Hey, you have a video visit with so-and-so, you have a phone visit with your doctor. I mean, that's what my mom gets, right? And she lives at home. So even people who live at home, I think is more as the medical complexity of the folks that you take care of need a little bit more where your staff's input is really critical. What they say is as important, if not sometimes more important, because it's more complete in terms of the information that you provide to the healthcare professionals. Especially those folks with memory loss. Right, your staff essentially become part of their family members. Right, imagine if you have a parent with dementia. I run a dementia clinic. We always talk to the family. The same time as we're doing our evaluation. It is not a complete visit without talking to the family member. So I think you're running into the same situation where you're just trying to really provide a more comprehensive information for the treatment.
Yeah, and I'll just add quickly from the legal side, it works from that end too. Yeah, you have the social model, that's RCFE, that's DSS, you got the medical model, DPH, et cetera, et cetera. But there's always been a healthcare component to RCFEs. You have prohibited conditions, you have waivers, you have exceptions, you have this, you have that, and the lines are blurring more, and it's because they have to if you're going to have address things holistically. So we'll see. There'll probably be some more action from the Department of Social Services on this, but I would think that they would be very sympathetic to well-controlled telehealth services, well-monitored telehealth interactions.
I think a follow-up question to that's coming up is around staffing. So Sherry, I know at Belmont Village, you staff your communities with licensed nurses. So for those communities that don't have licensed nurses or maybe have them in a management position, is there scope issues? Have you seen that you've had to change staffing patterns, training, or just boundaries of being able to set up with a physician or a physician's office of we can't do that? Like, where is that kind of slippery slope where you don't become a pseudo medical office for the physician?
Right. You know what? I think that goes into initially in setting up expectation and identifying, the needs of your stakeholders, which are your physicians, right? Because if you think about it, we're in the pandemic, they were thrown into, okay, now you need to start doing televisits, not going into the community. So kind of everybody was hit with the same thing. And, it's really establishing what is the appropriate protocols. No, it's not appropriate for us to remain on hold for 45 minutes. if you're taking staff off to help with the televisit, but then if you have a physician that gets upset because you're not right there standing by. What we've tried to do is take a step back in, the thought that throw a nurse at everything, they'll solve it. And while I don't disagree with that comment, I will tell you, it's a matter of looking at it is that the core that you're trying to provide is that visit. The rest should be invisible. So if we try to take a step back and say, did that resident need assistance going on the bus? Did we have a private non-licensed person with them? Well, then that probably would be appropriate for the visit. So not to, sometimes you just throw people in it, as a resource and you think it makes it better, but that's not the case. Where we really focus on nurses, trained nurses that have competency in telepresenting, is with the urgent care, the urgent telemedicine that we do, where we call that, we have these amazing board certified ER physicians on call 24/7. And we have an urgent case, we can call them and they know that whole process of what's important, what's presenting. So I think it's really, you have to separate what it is that you need, what you truly need, and go back, keeping it simple, ask why. If it's no, it needs a nurse, you need more nursing time. Well, tell me why, figure that out.
Yeah. Dr. Zhang, you talked a little bit about some of the hesitancy of physicians. Like, this is, for many physicians, a change in how they practice medicine. Can you talk about like some of those challenges with senior living and how we might do a better job of communicating with physicians so that there are those kind of expectations that our policies aren't automatically going to change because we've added telehealth, or that we're doing more telehealth, or that we now have some biometrics in the building? And how might we better support even some of the challenges that physicians are having with this approach to interventions and treatment and assessments?
Yeah, well, I'll back up a little bit. Maybe I'll address the sort of the physician part, where physicians are uncomfortable because they actually need training to practice telemedicine, right? So I'll give an example. I think maybe about 5 years ago, I gave a presentation on urgent care, where I was part of an urgent care practice where you could see a doctor on the phone. And for physicians who are trained in delivering primary health services, physical health services, we're taught that you need an exam. You need to listen to the heart. You need to listen to the lungs. For the doctors that we had, we had this mandatory requirement that you at least will have a video visit, and we'll train our doctors on how to do some physician-directed exams. And it turns out there was another practice where 80% or to 90% of the visits were entirely telephonic. I won't mention their name, but they were actually, both practices were just successful. And what was clear to me was that people adopted or adapted in terms of their diagnosis and treatment based on the information that they got. Right. So in order to make a diagnosis, let's just even use a respiratory infection. You have many parts of the information. A large part, actually 80 to 90% of a diagnosis actually centers on the history, the information that you get. Maybe about 5 to 10% centers on when you touch the person to confirm something. For example, if someone tells, and this is why most laypersons say, well, you have a viral infection. That sounds like the flu, or that's actually, you don't have the flu. A lot of lay people can make a diagnosis, but what the physician has is using an instrument to examine and then confirm a diagnosis. So a lot of physicians weren't quite comfortable with, well, I don't get to touch someone. But in fact, a lot of the medicine can be practiced. And this is why for emergency physicians, they go, well, hey, a lot of this stuff, it's not emergency. This, these people really don't need to come to the emergency room. And that's the bulk of our care, right? So I think the physicians, it took them a leap of faith to go, actually, I can practice telemedicine with the information that I have. Now, I think then translating to the assisted living program is going, well, okay, certainly we could give you vitals. We may even be able to attach a stethoscope for you to listen to the heart and lung. Well, what other information do you want us to do? Do you want an otoscope for us to help you examine the ears, et cetera, et cetera? Now, it's really hard for me to imagine that if you have a healthcare professional who's asking for more information, that you really need to couple that need for that information versus the urgency of the patient. And that is really a clinical decision where I think as a facility, you don't want to get involved, right? And going back to Alan is, you want to protect the facility. The facility's job is not to make a diagnosis. It is to give reasonable amount of information and then let the clinicians manage the job. If they can't get a particular information, maybe they should have the person go into the office. So that's where sort of my own personal information is. As you work with the physicians in your community, they're going to get to know your capabilities, and you're going to get to know sort of what they're comfortable with, and it just gets smoother and smoother over time.
Like most things, you have to build relationships with people, right? We can't be robots with our physician, or say, that the physician knows all, that there really is this relationship and this collaboration.
Exactly.
There's one specific question on the chat that I want to make sure that I don't lose, and it is around recording the telehealth appointments and the pros and cons of doing that, and if there's any legal concerns. So Alan, do you want to take that question?
Yeah, and I assume by recording, it means a recording, just like this session is being recorded so that it can be played back.
And we asked permission to have the session recorded.
Yes, okay, I was worried. No. There's no problem with doing that. I don't think it's necessary any more than it's necessary if a patient visits a physician in the physician's office, that the interaction be recorded. Now, the doctor in that situation will make notes, et cetera. And I suppose if the patient is with, it would usually be a relative or whatever, they might want to take notes, but it would be very odd to record the thing. Now, moving over to the telehealth interaction, I would begin with the same assumption that this is not something that just to be legitimate or whatever has to be recorded word for word. And I would tend to rely on the doctor's notes and the doctor's record, and then any notes that are made. I'm imagining now somebody more than just an IT technician who's there with the resident assisting, that they would make notes. And there's no particular I think way of doing that. Doctors are trained from the beginning to make notes and so on and so forth, to do it accurately and to be inclusive and so forth. I'm not sure that in this sort of emerging area that we have absolute standards for someone at the originating site with the resident doing it. And again, this is someone from the RCFE. But I would say it's a good idea to do it. And then only in unusual cases would it be appropriate to record it. I don't know, Glenn, what if it's a behavioral health consultation? Is there more of an argument for that?
Yeah, no, as I indicated, I think you really, Alan, as you alluded to, right, you really have to look at the indication or the intent of the recording. What are you doing it for, right? So for example, in our research project for asynchronous telepsychiatry, they're all recorded. We record all the interviews so that, because there's value in that recording in terms of allowing another diagnostician to, even for consultation purpose, to make a diagnosis. We actually use people who don't make diagnosis to ask us a preset of interviews to help someone else who's making the diagnosis. So in that case, the recording, is in it's the essence of a part of our treatment plan. Now, I will say that I will occasionally get family members in my clinic who say, well, can I record this interview? And sometimes we say yes, and sometimes we say no, but the official answer is actually no, because I think that the concern, Alan, this is actually more out of our legal counsel, just go, well, we don't think it should be recorded. And from that perspective, it really is just, we don't really know what the intention of the family wants. And I think it is sort of a blanket policy just to, but if someone really wants it, they have the right to have something recorded. And obviously, just like this session, the clinician has the right to say, I want it to be recorded or not. I think what it happens is sometimes people get really nitpicky about certain things. Well, actually, that wasn't 1 week. It was actually a week and a half. It actually doesn't really contribute to the treatment plan. It ends up people using a lot of time. It's kind of garbage in, garbage out. You fight. People often, occasionally I'll get a family who writes me a letter and crosses out a few things that I've said because I was missed by a few days or a few pounds. And that doesn't really add to the treatment. It sort of delays and makes the work less useful.
I have sort of a global question. In terms of operations, we've been talking about sort of pre-pandemic and in the middle of the pandemic. And now I think as operators, we're looking as we're starting to come out of the pandemic, what stays and what doesn't. So clearly, pre-pandemic, senior living was criticized for being slow to adopt technology and slow to adopt changes in models of care and delivery of all sorts of things, but healthcare included. And then in the pandemic, I think we were all just, let's do what we need to do to help our residents stay healthy, continue to thrive as much as they can. And we were forced in some ways to communicate with our healthcare providers in very different ways in our own personal life, as well as operators and clinicians supporting our residents. So we brought on technology in ways that we never thought we would or never thought we would so quickly. And now we're sort of in the now what, as we move toward opening up, as we move towards what is our new normal. How do you, as an operator, an attorney, and a physician, see what do you think is really going to stick, and what do you think is needs to be, well, this was part of the pandemic and we don't need it anymore? And we just have a minute or two left, so if you could just keep your remarks short, and then we'll turn off the webinar for the day.
Well, I'll just say,
you want to start?
Yeah, I'll just say very quickly. Medicare has already said that it's going to be pulling back a lot of the physician reimbursement. They feel that there's been some fraud there, so they'll be looking at that.
Great. Sherry, any thoughts?
Yeah, I think that, that we need to take a lead and be that first penguin in creating what is our new normal. And I think that there's lessons that we learned during the pandemic that will forever change, that path, that new normal path that you're going to take. And I believe that we're going to have to continue, that the market forces, the demand of the market forces, and the disruption in technology will lead us to really adopt these things quicker, to bring them on, still again, do small pilots. But I've always been a fan of technology with that background. So I hope that we'll be open to our new normal.
Yeah, I mean, Paula, I think for me, it's my last slide that I presented, right? I think it's going to be probably a mixture of a hybrid model of in-person versus telemedicine. And I think that is really where we're heading. And I agree with the pandemic, it was probably a little too much, and we're going to be coming back and doing a little less telemedicine and more in-person care. But I don't think we're going to get to, no telemedicine. And I think, like Sherry said, people are going to push where they live to provide this service.
Yeah, I wrote down your information about the no-show rates. I mean, even if that's behavioral health, but if that's just regular primary care too, that's an amazing way to follow up with people so that they're actually getting preventative, ongoing primary and medical care. So we are out of time. I feel like I could talk to you guys there's so many things that we need to go over. And I want to thank CALA for putting together this webinar, and thank all of you very much for sharing your expertise, and thank all the participants as well for being part of this webinar. And I'm sure you'll see more from CALA. So with that, we're going to end this session, and we will see you all soon. Bye.